This component that I'm going to be showing you is called Basic Shift Assessment, which is the foundation for your physical assessment that you'll be doing. We're going to be doing general survey, a little bit on mental status. We're also going to be doing a abdominal assessment, respiratory assessment, a little bit of cardiac assessment, and a peripheral vascular assessment. You have a guideline that's been printed for you with the priorities that you need to assess as an NUR 118 foundational student. And in here has all the things that will cue you and remind you when you're practicing this on each other in the nursing laboratory, or I encourage you to practice it on your family members at home. So I first want to talk a little bit about assessment techniques. The first thing that we should do as a nurse is inspect our patient, look at them. And you're looking at them what we call a general survey. You're looking at their demeanor a bit, their posture, their general skin color, their speech. Is it clear? Is it concise? And if a patient is in acute care, you're also going to be looking at line reconciliation. What are they attached to? Do they have a catheter? Do they have an intravenous line? Do they have oxygen? So that you can make a great assessment about lines, because remember, that's part of your general survey. The other thing you want to look at is their body type, and if they were sitting up or walking around, you could look at their gait and their balance, and if their extremities were well aligned, etc. So the first thing we're always going to do is inspect and observe for any system that we do in regards to physical assessment. The next thing we're going to do is palpate the patient. When we palpate a patient, we use our fingertips to denote a sense of whether we're checking at edema, whether we're checking pulse points for palpation. Remember, the rule of thumb is when you're checking somebody's temperature, which I will be on Monique in a moment, you want to use the back of your hands, because the inner aspect of your hands are typically pretty warm, and it could alter that temperature kind of mechanism. You're checking the temp throughout the body. The last piece, or not last piece, before last piece, is auscultation, listening to sounds that the body emits with a stethoscope. Remember, the stethoscope will amplify the sound, and the bell is used for more finite sounds. To be perfectly honest, I'm a person that uses the diaphragm for most anything, but again, remember that the earpieces go in a certain way. If you get it in the wrong way, then you won't hear the sound adequately. So we can listen to breath sounds, bowel sounds, heart sounds with the stethoscope. The last piece is called percussion, and it's an old science. When you percuss, you're actually taking one object and percussing over a body part. You can use your finger. Some people use finger over finger, but for me now, I don't have the strength to do that adequately to emit a sound. What I'm looking for when I'm percussing is timpani, dullness, resonance, sounds that are created when an organ or when there's a solid area versus a air-filled area. And I will be demonstrating this as well. So those are the assessment techniques. We're going to be doing breath sounds. We're going to be doing also apical pulse. We're going to be listening over the valves. We're going to be doing an abdominal inspection, and then a peripheral vascular. So before I start all of this, what I'm going to be doing again is washing my hands when I enter the room. I'm going to swipe. Hi, my name is Evie. How are you today?
I'm well.
You're well. Hi. So, I'm going to be doing a bit of a physical exam today. I'm going to start with just doing a little bit on your cognition and your pupils. I'm going to just check and make sure everything's working okay there. And then I'm going to go with your heart, lungs, abdomen, and your periphery. But first thing, before I get started, for safety purposes, could you give me your name and date of birth?
Sure. Monique Blau, October 21st, 1990.
Awesome. Well, thank you. And you're feeling okay and comfortable at this moment before we start?
I am comfortable. Thank you.
Okay. I'm going to put the rail down so I can get closer to you. Okay. So if I was doing a general survey on Monique, here I could see that she's a bit pale in color. Her lips are symmetrical. She she has a Johnny on, so she seems to be well attired. Her speech was clear and concise and appropriate to the conversation. So Monique, can you tell me what date it is today?
May 27th.
Okay. It's actually the 28th, but it's easy to lose a little bit of time. That's okay. And can you tell me, I introduced myself earlier when I was doing vital signs. Can you remember what my name is?
Evie.
Very, very good. When did you graduate from high school?
In 2002.
2002. Okay, so you're doing remote, recent, and current memory. Okay, and the other thing you could do for current, even more recent memory would be if you were in the room and she had had breakfast, you could ask her what she had for breakfast to see if she could remember that a short time ago. All right, so the next thing I'm going to do is I'm just going to check Monique's pupils to see if they're equal, reactive, round to light, and accommodation. Okay, Monique, just look forward. Okay. Her pupils are reactive, round to light. And then the last thing I'm going to do is I'm going to do accommodation. Okay, and her eyes are accommodating to the object. Okay, so the next thing I would do is I would make sure that Monique, I would look to see what kind of line she was attached to. She had a urinary catheter, an IV, a dressing. Those are things that you want to check first thing in the morning to make sure that the lines are draining appropriately and that everything is patent, etc. Also look to see if she had a cast or a splint or any devices that were attached to her are considered your general survey. So the next piece that I'm going to do with Monique is I'm going to do her breath sounds. Breath sounds, normally as air passes, it goes down into, remember air goes into your lungs, oxygen. Your lungs are just a conduit to get the oxygen into the bloodstream. Oxygen fuels metabolism. That's why we breathe. So we listen to a patient's breath sounds to see if there's anything impeding that. Is there congestion? Are there wheezes? Are there crackles? The other thing is that normally as air passes through the respiratory cycle, when it goes through the trachea, there's a definite inspiratory to expiratory cycle or inspiration to expiration cycle. As we start to breathe and it goes down into the trachea, the inspiration is short and the expiration is long. As it goes into the mid-lungs, as the air gets carried through there, the inspiration-expiration cycle is equal. And as it gets into the posterior or the lower lobes, the vesicular areas, what we call vesicular, it is equal. So bronchial sounds, short inspiration, long expiration, bronchovesicular, equal inspiration to expiration. And vesicular in the periphery is a long and short. And it's as the air flows through, that's the normal. So when you're listening to normal breath sounds on an individual, you're going to listen over the trachea, over the bronchovesicular and vesicular area. You're always going to compare side to side, and you're going to go from top to bottom. There are also other breath sounds that are called adventitious breath sounds. And your adventitious breath sounds are categorized 3 ways: crackles, coarse wheezing, and wheezing. Crackles almost sound like cellophane, and crackles are typically heard on the end of inspiration, and crackles indicate that there's some sort of fluid or a fluid status. In particular, when people have heart failure, we hear crackles. But you can also hear crackles with a really what we call moist pneumonia. Crackles do not clear with a cough. They will not change. You cannot cough them out. Next are your coarse wheezes. They used to be called rhonchi. We're not supposed to use that term, but you will hear it. And rhonchi indicates air going through congestion, mucus. Usually it's in the larger airways, your pneumonias, your bronchitises. And it's very sonorous, it's very loud, and it can change with coughing, and you can clear this with coughing. Your last breath sound category is called wheezing. Wheezing is caused by constricted airways. When the airways are constricted and the air tries to go through, it will cause a very musical, loud, squeaking sound that can be heard on inspiration and expiration. Okay, so what I'm going to do now, the best thing to do is to make sure that your patient can sit up. And you always have instruct your patient to breathe in through their nose and out through their mouth. So you should never listen over a gown. I'm going to do this so that we maintain modesty. And I'm going to first start over the tracheal area. Go ahead and breathe in and out. So she's got a very short inspiration, long expiration. Now I'm going to move to the bronchovesicular area. Breathe in and out. Okay. And again, bronchovesicular. It's very equal in sound, equal inspiration to expiration. It's also clear. I don't hear, so far, any adventitious breath sounds. Now, women have breast. We don't listen over breasts. So we listen underneath. And then a really critical area to listen to, and this is the vesicular area, is your laterals. And you'll often see a lot of patients who have heart failure, their cardiologists come in and they listen laterally. So what I'm going to do is I'm going to just put your arm this way. Go ahead and rest it. And I'm going to listen to Monique's lateral areas. Monique, take a nice breath in. Definitely long and short. I'm going to listen over here on the other side. The inflow of air is very much long and short and clear bilaterally. Now I'm going to listen to her back, okay? And remember not to listen over bones. You have scapula back here. And you're always going to compare from side to side, top to bottom. I'm going to let you rest. Now I know in the book it shows about 18 points to have a person breathe, but you can't do that. They get dizzy. Especially if they're clear, there's no need to do that. You have to let them rest in between, because if they're blowing off too much CO2, they'll get dizzy. Okay? So her breath sounds were clear bilaterally, anteriorly, posteriorly and laterally. That is a comprehensive respiratory assessment. Okay. The other thing with the respiratory assessment you will do later on is you will be looking at chest size, you'll be looking at capillary refill, general color, clubbing, and all those pieces. All right. The next thing I'm going to be doing is what we call point of maximal intensity for the apical pulse. An apical pulse is what we listen to, and you should listen to on all your patients, so that you can get accustomed to, from day one, listening to adventitious heart sounds, or what a normal heart sound sounds like. And as a young coronary care nurse years ago, I was taught to always listen to myself, which was normal at that time, and then listen to my patient if I had a question about whether the heart sound was normal or not. Now, we teach you in the first semester to do a point of maximal intensity. In order to get the point of maximal intensity, you need to go mid-clavicular line, fourth or fifth interspace, and that's where the point of maximal intensity, where you'll hear it the loudest, your apical pulse. Now, if you have breasts, that's not going to work. You kind of have to go under the breast in the best way that you can. Okay? If you're having some patients, you won't hear apical pulses. They have thick chest walls. You will not hear that. Sometimes to get an apical pulse, I'd have to turn the patient on their left side, and then that would bring the heart closer to the surface so I could hear an apical pulse. Now, apical pulses should be regular, and you're going to hear two sounds: lub-dub, 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 lub-dub. The lub is closure of the tricuspid and the, excuse me, mitral valve, and the dub is closure of the aortic and pulmonic valve, S1, S2. Tricuspid mitral, closure of those valves as blood goes through, and then S2 is your aortic and pulmonic closure of the valve. So, we're going to teach you not only to check apical pulse, but to listen over what we call the 4 valves. A point to make. Aortic valve is second intercostal on the right. That's where the heart is ejecting the blood out. You're going to listen over there to hear any abnormal blood flow, which would be called a murmur. A murmur, instead of having just a clean lub-dub, lub-dub, lub-shtub, lub-dub, you're going to hear these adventitious sounds, which means that the valve isn't opening or closing appropriately. So we're going to teach you to listen over the aortic, second intercostal on the right, pulmonic, second intercostal on the left, tricuspid, fourth or fifth interspace, and mitral, more medial. We're going to teach you to listen over these areas so that if you hear an abnormal sound over those areas, it'll indicate which valve is abnormal. So the first thing I'm going to do is I'm going to do her apical pulse. I'm going to count for a full minute. And anytime the radial pulse is irregular, you should do an apical pulse. So here is her clavicle. I'm going to go 2, 3. Okay, I'm going to listen to her apical pulse. I'm going to have you place that a couple of inches over from my finger. This is what I do with patients in cardiac rehab that are clothed. Lub-dub, lub-dub, lub-dub 1, lub-dub 2, lub-dub 3, lub-dub 4, lub-dub 5, lub-dub 6, lub-dub 7. I'm not going to listen for a full minute, but if I did, I'd say her pulse was 70, regular, with no extra heartbeats noted. Also, no murmurs, swishing, burring, abnormal sounds. Now I'm going to listen to her aortic pulsation right over the aortic valve. So I'm going to go down 2 interspaces. You're going to hear the S2 louder here because you're listening over the aortic area, which creates the S2 sound, right? Your aortic pulmonic, the closure of those valves. S2 is much louder than S1. I hear no murmurs, it's regular, and I hear no extra heart sound. Now I found her second interspace. All I've got to do to get the pulmonic is slide over here. So I've slid over to the pulmonic area to listen if there's any valvular disturbances going through the pulmonic valve. S2 is clearly louder. S1, S2 are regular, no murmurs, no extra heart sounds. Then what I'm going to do is I'm going to go 4 interspaces down and I'm going to listen to the tricuspid area, 4 to 5. Oh my, S1, you're a good candidate. S1 is much louder because remember your tricuspid and mitral valve create S1, the closure of the tricuspid valve and the mitral. Okay. Now I'm going to have you put it in the mitral area medially under your breast. Lub is much louder than dub. Tricuspid mitral, that's what creates the S1. And both the heart sounds are regular, no murmurs, and no extra heart sounds. You'll talk about extra heart sounds in the 4th semester, which are created by fluid volume overload in the heart. Okay, the next thing that I'm going to be doing is I'm going to be doing an abdominal assessment. So I'm going to put her down if she can tolerate it. Now remember, patients that have abdominal surgery, you want to be very careful. Sometimes you have to put a pillow under their knee to take the pressure off the abdomen. Okay. So remember, the first thing that you do with an abdominal assessment is you inspect. Now, in this system, there's a little change in order because with this particular system, you're going to first of all look, and then you're going to listen. You're not going to palpate or percuss because you can alter the bowel tones next. You're going to look, listen with your stethoscope to bowel sounds, and then you're going to palpate, percuss, and palpate. Okay? So when I'm looking at this, her abdomen certainly is not distended at all. Her umbilicus is midline and centered. She has a few little moles here. She also has very little striae. She has no hernias, no pulsations. Everything looks pretty within what we would consider the normal abdominal assessment parameters. Now the next thing I'm going to be doing is I'm going to be listening to bowel sounds. Peristalsis. Peristalsis, by definition, is an involuntary movement, right, caused by the central nervous system that moves things down through the bowel. We teach students to learn and listen in the way that the normal colon anatomy is. So this is ascending colon, transverse, and descending. You're going to listen. There's 4 quadrants here. You're going to start in this quadrant, ascending area, going to move up, go over here and down to here, because that's the way peristalsis flows. Normal peristaltic movement or bowel sounds, which means your bowel's alive, things are moving through. and very important for postoperative patients to assess these. You're going to listen to all the 4 quadrants and make sure that it falls within normal. So you should hear bowel tones in all quadrants between 5 to 15 seconds. If it is greater than that, we call it hypoactive bowel tones or bowel sounds. And if it is below the 5 seconds, it's almost going all the time, it's hyperactive. Now, in patients who have had surgery, for the first few days, especially bowel surgery, you may not hear bowel tones. It takes a while for the peristalsis to kind of reinitiate itself. If you don't hear bowel tones, you need to listen at least 3 minutes to conclude that there are none, because they can be intermittent sounds. So I'm going to start down here, Monique. You need to have your watch handy so you can time them. Hers are going constantly, so they'd be hyperactive in the right lower quadrant. I'm going to move here. Same thing, under. Okay, it is under 5 seconds. Going to move over here. This was about 6 seconds, so it falls within normal, 5 to 15. Same here. So she falls in the right lower and the right upper. She's got hyperactive bowel sounds because they are almost constant. Over here, in the left upper and left lower, she falls between the 5 and 15 seconds, which is the normal occurrence of bowel tones. Now, the next thing I'm going to do is I'm going to percuss her abdomen, and you should hear tympany over air-filled areas and dullness over a full bladder or a liver. So I'm going to take this instrument against my finger. Sounds pretty empty. Not quite as much, a little duller here. Over here is the gastric air bubble. So more tympany here. The next piece is that I want students to learn how to palpate the abdomen. And when you I'm putting gloves on because I may get down close to her pubis and her bladder. So when you palpate, you're getting a sense of any tenderness or any masses. So what I'm going to do is I'm always going to look at my patient's face. Is this tender? And you're not going to do the deep palpation that they'll teach you when you go on to school. Monique is in school getting another degree. We're just doing a light 1 to 2 inch palpation. Any tenderness? No. I don't feel any masses. I don't feel any cysts that move around. And as a nurse, I want you to be able to palpate the bladder, especially for a patient that's indicating that they can't urinate. And it's right over the symphysis pubis bone right here. Can you feel me on your bladder? Mm-hmm. Okay, it's not too full. Okay, great. All right. Okay, the last part of this assessment is going to be the peripheral vascular assessment. Okay, so when we're assessing the peripheral vascular system, we're assessing circulation that's running through the body, all right? All of that perfusion going through the vasculature. So when you're doing your peripheral vascular assessment, you're going to be checking pulse points throughout the body. Not counting them, just assessing them for amplitude. how well you feel that pulsation with your fingers. So we've already done the apical pulse, but when you're doing the peripheral vascular system, there's other components besides pulse points. You're going to be looking at general skin color. You're going to also be looking to see if the presence of hair, if, especially in a male, if they don't have hair on their legs, they have peripheral vascular insufficiency because you don't have enough blood circulating to your lower extremities. So men that have hairless legs, if they don't shave it, is usually due to a peripheral vascular problem. And our patients who have peripheral artery disease don't have hair on the lower legs, definitely. Okay, so you're going to be looking for hair. You're going to also be checking the temperature of the extremities with the back of your hands. Temperature of the extremities. Texture, right? Skin is soft. Okay. You're also going to be looking at capillary refill. Remember, if you depress your nail bed, it should fill with blood within 3 seconds. If it doesn't, you have diminished circulation. The other thing you're going to be looking at is nail angle. Patients with hypoxia have clubbing of fingers, and what happens is their nail angle exceeds the 160 degrees. You don't even need to measure it. You'll see the clubbing of an extremity. It's very, very obvious. So we're checking capillary refill, temperature, texture, turgor. General skin color is, her extremities are a little pinker. Her face is a little pink right now. Maybe I got her going, I don't know. Okay. So initially you inspect, okay, and you look. And then what we're going to be doing, the parameters with this, we're also going to be doing circulation checks, pulse points, sensory checks, because again, in order to have good sensation, you have to have good vasculature. That's why patients with diabetes who don't have good vasculature flow or flow throughout their extremities get neuropathy as well. And motion. Do they have good motor movement? People with peripheral artery disease do not. They have a lot of pain called claudication. Okay, so we're also going to be checking edema, fluid buildup in the tissue, second spacing of fluid. When we have too much fluid, it's going to leak out the vasculature and go into the tissue. So we're also going to be looking at that as well. All right, so the first thing I'm going to do is I'm going to check her sensation. There's a number of things that you can do. You can take a vibratory fork, close your eyes, Minnie, and tell me, whoops, when you feel the vibration.
Now.
And again, you do the same thing here.
Now.
Good. All right. The other thing that you can do if you don't have a vibratory fork, because they're not that common on the floors, you can also take a cotton and have her close her eyes and tell me when I'm touching you. Just say touch.
Touch.
Again, extremities. The other thing that you can do is a sharp and dull. Okay? So when you're doing sharp and dull, okay, the patient needs to denote whether it's dull or sharp. This is more definitive for sensory. All right? So, Monique, keep your eyes closed. This is sharp and this is dull. Okay? So you just tell me what you feel.
Sharp, dull, sharp, dull, sharp, dull, sharp, dull, sharp, sharp, dull, sharp, 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 dull, sharp.
Okay? So, sharp and dull. So her sensory input responds to sharp and dull, touch, and the vibratory fork. All right. The next thing I'm going to do is get a general sense of her muscle function. So to get a general assessment, what I'm going to do is I'm going to have her squeeze my hands, okay, push against me. All right. Now, I want to have you try to adduct your arm towards your body. Pull it in. Okay. Push it out. Pull it in. Push it out. Okay, good. Especially important with patients with epidural drips. Okay. I want you to bend your. Okay. Now I want you to push against my hand. Okay. Again. All right. I want you to try to pull out. Pull it, pull in, pull in. Okay, good, sorry. Push out, good. In. Okay, great. So you get a general sense she's got good resistance against opposition, good motor activity. Okay? So that's the C. The C I'm going to be doing in a moment, more circulation pulse points. The S, sensory and motor. So now I'm going to be doing the pulse points. I did her radial earlier, and you're going to rate them on a scale of 1+, 2+, 3+, and 4+. It's all in your handout. 1 + 0 means I can't feel a pulse. 1+, I'm not sure I feel a pulse. It may be a little thready, a little weak, I'm not really sure. And the point is, if you get a 1+ or 0, you need to get a Doppler, which I'll show you how to use in a moment, which amplifies arterial sounds. It's very, very important after people have vascular surgery that you make sure they have pulse points in the operative extremity. So, 0 means you can't feel one. 1+ is diminished. 2 is normal. 3 you can feel very easily palpable. And 4, it's bounding. You can almost see it pulsating. All right? 3+, that's the brachial. Radial, I'm sorry. That's the radial, excuse me. This is the brachial. This one's about 2+, and that's not uncommon for that one. Okay, I've already done her apical pulse, and now I'm going to move to the femoral area. When you're doing the femoral pulse, especially, you better get accustomed to where that is, because when you have a code situation, that's where you're going to try to find it. It's a pretty big artery, that or, okay. Okay, so it's in the panty line, so you have to, it's deep. So you have to put your hands down in the panty line. I feel yours, you feel me on it? Mm-hmm. She's pretty thin, so she's easy to find. It's a good 2 to 3+, it's pretty good. All right. I'm going to take this off. Panty line for males and females. Now, the popliteal you won't find in a lot of the population, especially if you have a thick leg. The popliteal pulse is right under the knee, and I use 4 fingers in hopes that I can find it. Oh, I found yours. Perfect specimen. Okay, 2+. Now, this is where students, when we know students don't know what they're doing, there's a pulse point underneath the malleolus, right here, okay? Inner malleolus, okay, not outer, inner, okay? This is called the posterior tibial pulse, and this is a 2+, okay? You also have a pedal, dorsal pedis pulse. that runs on, and when people have surgery, typically on their legs, vascular surgery, you need to make sure that these are present, the pedal and the posterior tib. So the posterior tibialis, what you're going to do is run it through the first and here's the road to it, so to speak, in between the first and second toe, and then it's usually down here a bit. Got a good pulse, 2+. Okay? All right. Now, I'd also check capillary refill, but I cannot on Monique. She has some pretty blue polish on. Okay. So now let's say her pulse was 1+. Let's say I wasn't sure I felt it. On all of the acute care units, okay, we have Dopplers that amplify sound. It's kind of the same Doppler that you use for babies to see if their pulses in there going on, right, when they're in utero. You need to put an ultrasonic gel, okay, on the end of the probe, and you need to put a lot, like you put for your toothpaste. Okay. So you can do. Okay. Now, because these pulse points are small, you need to swim around to find them. Just relax your foot. I can hear it. It's not very loud. I'm going to try the posterior tib. See if I get some better sounds. I can hear it, but it's so low. I've got it, but I don't think you can hear it. It's okay. All right. What's really important when you use equipment on multiple patients, because Dopplers are very expensive, okay, that you clean the equipment, okay, in between use with your cavi wipes, okay. The next thing that I'm going to be checking is I'm going to be checking for some edema. Now, typically edema, fluid, swelling, second spacing, fluid escaping the vascular space into the tissue. Gravity will float it down first, so you get in your feet and your legs. But sometimes people have edema, severe edema, all the way up, even in the sacral area, and it's called anasarca. But typically what we do, right, especially for people with heart failures or venous insufficiency, is we check for edema, typically around the ankle area, around the tibia. This is where it'll sneak, and you really have to, when you're measuring edema, you go with a scale of 1 to 4+, and 1+ is when you depress into the tissue, it'll depress 2 millimeters. So 1+ is 2 millimeters depth, 2+ is 4 millimeters depth, 3+ is 6 millimeters depth, and 8+ is 4+. 8 millimeters is 4+. So sorry. Okay, so I'm looking for edema here, and I don't see any depressions. She has no edema at all. She has no swelling. And sometimes with people who have a lot of swelling, you're going to go and you're going to notice it all the way up the legs and into the abdomen, okay? If they have significant fluid overload, heart failure, venous insufficiency, whatever the issue may be. So edema check is the last piece that we do. Did I forget anything with the peripheral vascular that you can think of? Nope. You sure? Ruber, okay, yeah. So we did talk a little bit about where we checked about general color. Remember, people with peripheral artery disease, no hair, and they have a rubor, especially dependent rubor. They're going to put their legs down and they get bright red. People with venous insufficiency have this brown deposition of material, brown hemosiderin, and it's caused by lack of adequate blood flow to the surface of the legs. Those are kind of classic things. You're going to learn the difference between venous insufficiency and peripheral artery disease this semester. So this pretty much concludes our basic shift assessments that you're going to learn this semester, and you should practice universally throughout the clinical setting. Thank you.